Good morning, everybody. Thanks, Justin. What a great event you guys have organized here. I know how much work's been put into it. A great kickoff last night with the CIO roundtable. If anybody was in the last session, my takeaway from that event was this is the place. A lot of the panelists said this space is where they want to be. It's exciting. It's scary, as kind of we heard in the last session, but it's the place to be. This is truly an area, and you're going to hear a great speaker next who can share his experience, not just in cybersecurity, but security in general, and the journey that Alberta Health has taken. So, really quick, I'm Mike Thompson. I'm the managing partner in the U.S. and president of our Canadian company, ICSynergy Inc. We've been in business since 2000. All we focus on is security, and we drill down to typically identity and access management, database security, and cloud security, which is truly emerging. And I'm hoping that'll be an aspect that will be definitely discussed at this conference. So on to our speaker. I've been really fortunate to know Robert and a great team at Alberta Health Services over the course of the last 6 years. One of the things we strive for is partnering with our clients, and this has truly been a great partnership. And especially when you think about the size and complexity of Alberta Health Services, and honestly, I spend most of my time in Dallas, a lot of time up here in Canada, originally from Ottawa. I tend to sometimes forget about how big and complex Alberta Health Services really is. So it's kind of neat to think about a public sector, acute, tertiary, emergency services, primary long-term care with 120,000 odd. And Rob will correct me if I'm off. Staff physicians, 500 facilities, and a $13.4 billion budget. At least that was from the last chart deck I saw.
It won't be that high.
It won't be that high. I made a bad joke. I was with Robert and the CTO for Alberta Health last week, and they looked at me after our meeting and said, "What's wrong?" And I said, "The market is down 545 points on oil." I thought, Alberta oil, big mistake. Big mistake. So, Robert is the Chief Information Security Officer at Alberta Health Services. He's co-chair of the Alberta Health Services Enterprise Risk Management Executive Committee. He has governance, he has risk. He's going to tell you about all of the things that he's responsible for and really deploying a security awareness program to a lot of very important people. I can tell you one thing, Alberta takes their healthcare extremely seriously. I've looked at the annual report, and it's always at the top is how we make sure that the citizens get the best healthcare in the world. So, professional engineer, just a great speaker, one of Canada's leading executives in the security space. I honestly can say that because I know a lot of the executives in Canada. I'm really proud and honored to introduce your next speaker, Robert Martin.
Thanks, Mike. Build me up overly. My name is Robert Martin. I am the Chief Information Security Officer at Alberta Health Services, and I'm very happy to be here. When I did look at the schedule earlier, I thought that I was going to be competing against Jeff Besko, because his talk was going to be at the same time as mine. So the good thing is I don't have to get his talk changed. He's going to be speaking in the afternoon. The bad thing is that he's in the room with me right now, so he says he's going to heckle. So lots of people that I know as well as Mike. So thanks very much for having me here. This is really great. What I want to talk to you about today is not going to be about tactics. I'm not going to talk to you about technology. I'm not going to talk to you about any vendor A versus vendor B type of stuff. That's not my role. I'm not an operations guy anymore. I don't have any operational teams. I work on governance, risk, and compliance, and policy and investigations. And so I'm not going to get into speeds and feeds, but what I'm going to try and give you is some perspective on what AHS is like as an organization, why I've been in this role for 8 years. Jeff and I were talking about that just this morning, and things have changed in the last 8 years, every probably 6 or 8 months with AHS. So it's been a very dynamic organization to work for. And through my career, I've been able to really mature how I think about security programs over the last several years. And I want to share with you a few of those learnings, and hopefully you can take a couple of the anecdotes that I have and apply that to your own programs. And so one other thing I want to talk about, I'm mic'd up, which is good. You can probably hear me quite well. I'm suffering from a bit of a chest cold, so if I start to talk a little bit quieter, just wave your hands and let me know, and I'll speak up a little bit. So Health Information's Balancing Act. The balancing act that we have to talk about really is between security and access. I don't think anybody here is really going to have, that's not really going to be a surprise, right? What is security? Well, security is the protection of the information. And in healthcare, one of the things that I've learned over the years is that it's really important to have access to information to change health outcomes. And so one of the things that's really interesting about healthcare, anybody here in healthcare, I guess? Anybody here a physician? I want to make some physician jokes a bit later on, so no? Excellent, good. No, I'm not going to make any physician jokes. So from a security perspective, you have to protect the information, but if you want to change health outcomes, whether you're talking about health outcomes for an individual or for a population, or you want to do any sort of health planning, you need those large data sets. You need to be able to have access to the information. And that was a real big learning from in my career in Alberta Health Services, that how important research was, how important analytics was, and how important multiple people having access to that data was. So I'm going to take you back to 1989. For those of you that were in Alberta, which is probably not very many of you, in 1989, the Premier Don Getty asked Lou Heinemann to deal with a commission called the Rainbow Commission to deal with changes in the health system. And a lot of things came out of that, some really interesting things. They talk here, you can see in the quotes, the phased-in budgetary shift to prevention. That's really the mantra of spending money to keep well and not having to go into a hospital to be sick. And people have been talking about that for 40 years, and we don't see a lot of progress on that, but that's an interesting concept. They talk about regionalization in that report, which of course is, we went through in Alberta, 17 regions, 9 regions, and then Alberta Health Services, instead of 240 odd hospital boards. And then the thing that's really important for this talk is the bolded text, the better health data collection potentially through electronic smart cards. And there's an and ... at the end there. The last bullet, last part of that sentence was about privatization of healthcare. I didn't want to include that because I'm not going to go there today. So what the concept was, and this is 1989. This isn't like 100 years ago. This is like a quarter of a century ago. But the concept was you're going to have a smart card, and when you go to get your lab data, they'll put the information on the smart card, and then you're going to go take that smart card and you're going to give the smart card to the GP. And they're going to then write you a prescription, and they're going to put that prescription on your smart card. And then you're going to go to the pharmacy. And when you go to the pharmacy, you're then going to have that prescription filled, and then you're going to go back to the GP. And your health information, all of that is on this smart card. And from a security perspective, that's wonderful, because the only person that has access to that information is me, right? I am in complete custody and control of my data. Now, there were provisions in the Rainbow Report, to be fair, talking about research and secondary use. But for the most part, I was going to be responsible as a citizen in Alberta for my health information. All of those planning aspects with regards to research, with regards to changing the outcomes for populations, 45-year-old male with 2 kids living in Edmonton and presented in the emergency department the last 16 months, and those sort of scenarios you would look for aren't possible if I have that access, if all my information is on. Sorry about that. That was really embarrassing. So the interesting thing is now I have a great security model. I have a bad access model. And so 1989, what's the world look like? The world looks like paper-based charts. It looks like a traditional healthcare organization. And it looks like the future is going to be with regards to having the information on individual smart cards. Of course, that never happened. We can talk about all the reasons why it didn't happen. You can talk about, a floppy disk in 1989 and how much data you're not going to get any medical images on that. But conceptually, it's different than the model of what healthcare looks like today. And so what does the future look like? Well, the future really looks like quantified self, right? Looking at all of the steps I take and how well I slept and the calories that I ingested and what's my heart rate. It looks like home monitoring and not just home monitoring so that I can know my blood pressure, but home monitoring so that information then gets shared to my physician. And my physician then is going to be mobile. My physician is going to be significantly more technology adept than before. So wearables versus home monitoring versus your Fitbit or your band or whatever, and then clinical information systems. That's really the future that we're trying to prepare for. And from a security and an access point of view, if this is the world that we're going to prepare for, what are the steps that we need to take to get there? And so what I want to do now is take a look back at where we were when AHS was formed, what AHS is as an organization, some of the formative events in our history. We call them the formative events because they were brutal to go through. And then I want to talk about how our plan has evolved and how we've seen a shift in our own thinking from that sort of 2009 timeframe to 2013 and today. And then again, how we prepare to look forward. Mike stole a little bit of my thunder with regards to what AHS looks like. We are public sector. Of course, we're in Canada, so that makes sense. Acute, tertiary, and emergency services. We have some primary care. We have some long-term care. We don't have all primary care. We're not responsible for everything in primary care in Alberta, but we do have a lot of ambulatory clinics. When I prepared this slide originally for the ICSynergy Edmonton chapter annual general meeting in September, I went to the website and I saw, well, staff and physicians and volunteers, about 120,000 people. When I started preparing, I don't know if you saw the interview that Brian Clendenin from Box did with me for IT World Canada. When I did those numbers, this is a couple weeks ago, I said, well, it's 123,000 because that's the most current number that we look at. And then our communications people, if you read that article, they said, well, actually it's about 130,000. And so what does that mean? Does that mean that we're growing? Does that mean that we're hiring people like IT people or doctors or clinicians? No, it means that the how we see ourselves and the partners that we have, that we work with, is increasing, right? So when we first started looking at ourselves, I had a slide that I pulled out of here from a presentation I gave in 2010, where we said 90,000 plus, right? In that time between 2010 and now in early 2016, we see ourselves not as the 90,000 nurses and physicians and corporate staff in Alberta Health Services, but we see ourselves as also the 6,000 people in Covenant, which is the faith-based care, and the 17,000 volunteers, and the 6,000 physicians, and the partners with regards to the various other universities and research organizations that we're affiliated with. And so that number changes because our perception of who we are and who we're working with changes. So the comment I asked about, do we have any physicians in the room? So for those of you in healthcare, you'll probably understand this really well. Fluid relationships with physicians, external clinicians, researchers, and universities. That's my way of saying that our world is really complicated, because as physicians come in, one of the docs I work with, Tim Graham, he's a great guy. He's an ED doc. He's an informatics specialist. And he is an associate professor at the University of Alberta. And when I look at him, he doesn't look at him as the associate professor and then as the ED doc and then as the informatics doc. He just sees himself as Tim, right? He just is fluid in and out, and he thinks, wants access to all of his information in any context whenever he happens to be. And my job is to protect him so that he's not doing something bad when he has one hat on but in a different context looking at data, but also to enable him to be able to take all of those different things that he does and give him access to the information that he needs. And it's a tough job, but it's really interesting. Limited direct control and only as much influence as we create. I think that's probably the biggest mistake that I made in the early part of my career at Alberta Health Services, is that I was thinking like an IT guy, an engineer, I was thinking like a security guy, and that I needed to control things. I needed to put controls in place that people would have to respond to. And I think as we go through, you'll see one of the themes as we go through this, I'm a huge fan of organizational change management now. And everything I do, I think of it as a change management exercise, because I need to get people bought into these things. We'll see this when we talk about COBIT, we see this when we talk about lots of other things. If we can create influence and get people on board, especially in healthcare, they're going to respond significantly better. And of course, we have legislation and oversight and policy, et cetera. So that's really what AHS is like. I probably could talk the rest of the day about all of the changes in AHS over the time, with the board changes and the CEO changes and the minister changes. I will just leave it at that. If you're not familiar with what's happened in AHS in the last 6 or 7 years, it might be an interesting hour of your life to read a couple of the stories and all the different CEOs we've had. It's made for a very interesting career over the last few years, for sure. So I'm going to take you back in time in the AHS time machine. So if you're an old guy like me, you'll recognize the Doctor Who thing. If you're an old guy like me with kids that are young, you'll recognize Mr. Peabody and Sherman. And I'm going to go back to 2009 and two of those deformative events, right? I guess in healthcare we should call them sentinel events, but anyways, June 2009. And so it's important to understand June of 2009, because we're going to talk about the second date in a second. And this handsome guy there is Bill Trafford. Bill was, at the time, my boss and CIO, and I got him on the newspaper of newspapers around the world, even in Belgium, which was really interesting. So one day I'm sitting in my office, and one of my bright young analysts calls me and says, "I need to talk to you." I said, "Well, I got an opening at 2:30. Come see me then." "I need to talk to you now," he said. "Oh, come on in." And so he comes over and he lays out for me how the team found this previously unknown variant of the Conficker virus ravaging our environment. And if you know what Conficker was like, it took all of the web interactions on that computer and took all of the text information and then encrypted it and then sent it to a command and control server. And so we intercepted that traffic. Right? So it's really important to understand that. We found this, we stopped it, we decrypted it, we identified the 11,582 people that were potentially impacted, and so why is this a big deal? Well, it's a big deal because we couldn't prove that it hadn't happened before, and I'm not really proud to say this, but that's the only time in my career when Thomas gave me that news that I said, I got to bury this. Right? That was my first reaction. I got to bury this. To my credit, I very quickly said, I'm not going to bury this, but I am going to get fired. And so Bill probably gave me the single best bit of advice I ever got in my career when dealing with a crisis. He said, "You cannot let this incident define you. You have to be defined by how you respond." And I'm like, oh, there's hope. I'm not going to get fired. And so we worked really hard. We published this information. We didn't know that these people hadn't had their information copied to the command and control server in Cincinnati before. We did stop this, but it might have happened in the past. And so we published this and we got our heads handed to ourselves in the media. And so that was June of 2009, right? So the next deformative event was July of 2009, so 6 weeks later. And so laptops with patient information stolen from Alberta Hospital. And so for those of us that were at all involved with AHS at the time, and there's one other person here in the crowd that was there, at least one other person, really interesting to see, they call it the University of Alberta Hospital, and in the second line they talk about Alberta Health Services. And if you've been through AHS now, they don't talk about the hospitals anymore, they talk about AHS, especially when it's bad. And so a couple laptops, 250,000 people, name, birth date, personal health number, lab test results for communicable disease. 2 laptops are stolen out of the provincial laboratory building on the U of A hospital complex. Our privacy commissioner at the time, Frank Org, if you look down through the article, he was shocked that the 2 laptops were not encrypted. And then the quote, I'll read the quote out because I'm sure you can't read it. The standard in Alberta for storing personal or health information on portable devices is encryption. I can't accept anything less. And what gets lost in that news story is that we had encrypted 97% of all of the computers in AHS. And the last organization that we were scheduled to do was the provincial laboratory. And so somebody, they busted in the door, they took the 2 laptops, they probably took them to a pawn shop, got $25 and a bag of smack, right? It's not, they didn't do this to get the health information. But we don't know that, right? And that's the concern. So you have to assume that the information has been breached and you have to do the notifications. So June, big issue. July, big issue. And then Bill's showing me emails from the board members to our CEO at the time, Stephen Duckett, that are basically saying, is your security team completely incompetent? And well, interesting. And so I looked for a picture of a board. Now, every picture of a board is happy, right? It's like, hey, I'm on the board, aren't we great? And what, this is 12 Angry Men, right? If you saw the 12, because I needed a picture of a bunch of dour faces, right? Of course, our board at that time had some women on it, so it wasn't all 12 Angry Men. But when your board looks like this, and when they're coming after you and saying, basically, are you incompetent? You have to respond. So, one of the things that I'm going to, sort of a common theme through the rest of the presentation, the lessons that I learned, I didn't learn in real time. Right? So all these insight, it's not like, oh, I just learned something today. This is all hindsight, right? So this is the application of hindsight and the things that I learned over time. Some of them, in the moment, and some of them looking back a couple of years later. And so, in this situation, what doesn't kill us makes us stronger. One of the things I realized at that time, I had no FaceTime at the board. I didn't know any of the people there. They didn't know me. They had no ability to have any confidence in me. When I did get a chance to go to the board, starting to go to the board meetings in 2010, I went there as, a left-brained engineer in IT. And I didn't go there as a person speaking to the board. And again, when you get your head handed to yourself because you're not speaking in a language that they understand or that they want to hear, you have to respond pretty quickly. Learning to speak audit and learning to speak board is a bit of tongue in cheek, but I think it symbolizes the skill of talking to those executives. Being concise and authoritative. You have 7 minutes. What are you going to do in your 7 minutes, right? You're going to talk for 3 minutes and answer questions for 4, and then you're going to leave, right? Well, but this is really important. I need 25 minutes. Well, no, you're not going to get 25 minutes, kid. And I think the other thing I learned was, go there to present and listen, and not just tell. And I think that's obviously good life advice. But I think one of the things that I learned in the early days was, the board members are business leaders. They're super smart people. They've seen a lot of stuff and they have opinions and they want to share their opinions with you. So you need to listen. But the biggest thing that I learned in this is that I needed a plan, right? I'm an IT guy. I know everything. I'm just going to do stuff, right? And I hadn't articulated a plan. And to be fair, we had just formed AHS IT 7 months before. We had just done our road shows a couple months before this. We didn't even know what was in our budgets from what contracts we had. We didn't have all of our teams. So there's lots of extenuating circumstances of why we didn't have a plan. But when you have those two issues and you don't have a plan, the board gets really upset. So what's our plan look like sort of circa 2009, 2013? Well, at that time it was really heavily technology focused. And part of that was because we're IT, but part of that was, I had a multi-million dollar security program in 2009. But the first project I had to do was an IP readdressing project, because all these previous organizations all had their main router at 10.1.1.1, right? If you know about addressing, and so you can't do any routing and therefore you can't enable the organization because you have to readdress all these computers. So that was a big thing. Identity management was going to be really big for us. It still is really big for us. It's hugely important, and Mike's done a great job in helping us. But think back to those two big events in 2009, right? We had a virus potentially send information out, and we had laptops that left. And so we got really concerned about data loss prevention. So in 2009, we were going to spend a bunch of money on data loss prevention. By 2010, we said, that doesn't seem to be a real product that we're going to really get some, that we're really going to be able to get some value on. Nothing against the vendors, but just where we were maturity-wise in the organization. So I went to my boss at the time, Michael Long, and I said, I'm going to divert the funds from DLP to my security incident event monitoring tool. And I want to do that instead. And I think that's probably the single best technical decision we've ever made. That gave us all the operational visibility. It gave us the ability to do investigations. It gave us the ability to find the things like the configure variant significantly faster. We were going to do a lot of work on COBIT. And so I went to the board, audit and finance committee, and I'm sitting there talking to one of the members, and a very well-respected, influential woman on the board. And I said, well, the great thing about COBIT is it's going to let us speak audit to you, right? And she's like, oh, that's so good. Oh, I can't wait. And I'm like, oh, that's excellent, because now I'm getting FaceTime with the board. They're responding properly. This is fantastic. And so I turn around, buoyed by my success at the board, and I go back to IT, and I say, COBIT, COBIT, COBIT. And my IT peers said, we don't want to do that. And I said, well, what do you mean you don't want to do that? And I think that's when I first realized that, I need to build the whole change management aspects into what I do. Right? All my IT brethren saw with COBIT was a pedantic, theoretical, bureaucratic framework that was just going to make their life hell. And instead of that, we took a step back and we built an IT control framework based on COBIT. And we went through a standard, if you know anything, change management, the ADCAR model. You build the awareness, the desired knowledge, etc. And we got COBIT pushed through into our organization. And it's been fantastic for us. But when I went there and said, the executive and the board want us to do COBIT, I still needed to sell it inside of IT, which I think was a big epiphany for me. Incident response is a real big deal for us. You might joke that we had a great incident response team because we had so much practice, and you'd be right. But we built an incident response plan and we reacted properly. We had two different response processes in IT at the time, though. One was with my security teams, and one was with service management. So for a problem management, major incident, downtime process. And those teams were butting heads. They were getting into each other's way. We didn't know how to respond to which protocol to use, which incident response to use, and it was a pain. So I went to Michael, my boss at the time, and I said, Michael, I need to have that team come over to work for me. And it took me a couple months, but I convinced him. And this is the control versus influence thing, right? I figured the best way to do that is to have control over the team, have them report to me, and I can make things work. Where, today I would probably do it significantly different and do it through influence. As it turned out, I think having service management report to me was a great decision. I got at it from the wrong way, but we'll talk about service management in a bit. So halfway through our plan in this time frame, Shawcourt. And you probably heard about Shawcourt, right? There was a transformer explosion, and then a fire, and then the fire suppression system, the water, goes, and there's no power, and our data center is completely offline. And learned a lot in that time frame. One of the things that we learned that was really interesting is that the person that, from the fire department that is responsible for letting you back in is not going to let you back in, even if you just want to check to see how the servers are doing, right? So that was a huge event for us. So we were down for, I think, 62 hours. 62 hours to get to the point where we could turn the servers back on, right? And we're IT people for the most part, I guess, right? You get the servers back on, then you have to get your storage arrays back online, and you probably have to do a whole bunch of disk checks or whatever they call them nowadays, Jim, I don't know. That kind of thing to make sure that they're fine. Then you get the databases back up, then you get the applications back up, then you get the interfaces back up. And by this time, 4 days of all those things being down, all of our clinical information system had gone into downtime procedures and everything was done by paper. So now we had to take all that paper and input it into the system and do the reconciliation. So it was about 96 hours that we were down. And there's lots of issues here. We could talk about architecture. We could talk about the decisions to not invest in some failover. What I want to talk about, though, is what happened as a result of this process. And so our infrastructure team said, we need to figure out where else we have risk in the organization. And they hired an external consultant. The external consultant came in, did a whole bunch of interviews, and came up with a list of 160 critical applications. Now, 160 critical applications, right? That's a completely accurate number, but it's absolutely useless to us, right? Because how do you prioritize with 160 applications? How do you say, oh, I'm going to focus my investment on 160 applications? You can't. It's not usable. It didn't give us the ability to prioritize. It was completely reactionary. It wasn't risk-based. It was in the heat of the moment, and it wasn't necessarily a bad thing that we went through that process, but it wasn't necessarily useful for us either. The other thing that was really interesting from my perspective is that my team had no involvement in that process, and so we start thinking about this, and why weren't we? Well, we didn't have clear delineation of who was responsible for disaster recovery, who was responsible for business continuity at the time, and that was another thing that we said, well, we got to fix this, and so getting back into the plan now post 2013. So we've now recovered from Shawcourt. We've gone through a couple of years of an original plan. Let's take a look at how we're going to focus on things going forward. And the three most important things, starting in 2003, were risk, risk, and risk. And it sounds a bit trite, but I want to give you a bit of a story. We were called IT security and compliance. And everybody knows what a four-letter word is, right? Those are the words you don't want your kids to say. We had 3 4-letter words in our name, right? IT, you can't do anything right. Security, all about no. Compliance, all about me telling you that you're doing your job poorly. and so we were going through a reorg in early 2014. And so I had an operational team, a user account provisioning team that moved away to the infrastructure team. That hadn't happened yet. So all of my direct reports, my mandate was the same. My mandate was the same. My direct reports were the same. Nothing had changed, but I wanted to change the name. So I said, well, what about information risk management? And so, like, the toner on the page is still wet on the org chart. And I get a call from one of our directors on the infrastructure team, a really great guy, but somebody that never calls me. And he calls me and he says, hey, You're the risk people. How can you help me solve this problem? And I put the phone on mute and go, what? And I just took the phone off mute and go, I'd love to help you, right? And it was really interesting. It was one of those things where all of a sudden we could be somebody that other people wanted to help them, right? We weren't about compliance. Well, we're still about compliance. We're absolutely about compliance. We're not about security. We're absolutely about security, right? But they could see us as being risk people. They could see us as being somebody that could help them and not just get in their way. And that was just an absolute epiphany for me. And I took that away. I went to my team and I said, Tom called me. This is pretty crazy. What do you think? And we all said, well, this is the future. This is what we're going to be. We're going to be about risk from now on. We had the service management team. I talked about service management earlier. So service management came over because of the problems with our multiple response processes. And so we had trouble integrating service management into the security team for a couple of years. When we moved to the risk focus, all of a sudden service management, yeah, I get it. They're about standardized processes and they're about making risk go away in the organization by documenting things and by thinking things through in a mature basis. So all of a sudden service management goes, yes, we're part of the risk team, not part of the security team. And they got that. And it also gave us the ability, because we're focused on risk, to go through a process with our friends in enterprise risk management to take a look at the applications that are most important to us in the organization. So we have a HR management system and 3 major clinical information systems. Those 4 systems are the ones that we have to deal with and protect the most, invest in the most. And there are exactly 15 systems that feed into those as well, for a total of 19 systems. So if we could, instead of responding in the heat of the moment as an organization, come up with a list of 160 critical applications, we can now take a look at it from a risk point of view and say, here's the 19 critical applications. Well, now we have the ability to prioritize our vulnerability assessments, to prioritize our control system testing. More importantly, though, broader across IT, we now have the ability to invest. We know where we're going to put our investments. We're going to invest in the 19 critical applications before we invest in anything else. And so that was a really good, valuable thing that we could provide to IT. If you go to our executive now, our entire executive will be able to tell you the 4 critical applications in the organization, which is really important. So a little bit more about our plan. In 2013, we were fortunate enough to go through a IMIT strategy process with all of our provincial stakeholders, all of the associations, colleges, and unions, and universities, and the ministry. As part of that, we came up with 4 pillars. We'll talk about it in a second. And then over time, I went from backfilling for Michael and Bill on our enterprise risk management team to being the member that was there on a permanent basis to now co-chairing it. And I can use that as a way to say we have to standardize on the risk heat map that enterprise risk management uses across the organization. We can't have every project or mental health or finance have their own risk heat map. And similarly, we had a 5-point maturity scale in IT. HR had a 3-point maturity scale. Some other people had a 4-point maturity scale. And when all of these different reports are going to the executive and governance, and they're all different models, they can't make any correlations between them. So we really were focusing on that consistent application of the frameworks across the organization. So let's talk about the 4 pillars. So enabling, collaborating, responding, and assuring. I think these are fairly obvious if you think about it from a risk management perspective. We want to be enablers. We don't want to be barriers. When we did our road shows across the province when ICSynergy was formed, I got up in front of all the people and I said, we're no longer the no people, we're now the yes but people. And I thought that was pretty transformational, and I should get a pat on the back. And then people said, well, actually, grammatically speaking, you should be the yes and people. So anyways, so we want to be enabling. We want to be collaborating. This is all about the health data we talked about. We need to have health data be shared to be useful. And if we're not collaborating with our university partners, not collaborating with our researchers, then we're not going to be able to change the health outcomes. We talk significantly, ad nauseum, if you will, in Alberta about bending the cost curve. And you bend the cost curve by having access to that data to make better decisions. The third pillar is responding. I think that's, we talked about that, that's the one we do the best in our organization. And then finally, assuring. Assuring is just about providing confidence, right? It's about the board not having to say, is your security team completely incompetent, right? And so 18 months or so ago, I was at the Audit and Finance Committee, and the one member on there, he looks over at me and he says, how do I know that you know what you're doing? And if you think about it, it's kind of funny, right? He's a pretty straight shooter kind of guy, obviously. But what he was telling me, and we had a long conversation about this, is he wants to be confident in me that I know what I'm doing, right? I get that 7 minutes in front of the board. In that 7 minutes, he has to know that I've advanced the cause, that I've the things that were priorities before, I've dealt with, the things that he's concerned about that he's hearing about his other boards, we've got a plan in place. And he just wants to know that I've got that done. He's got, on that audit and risk committee, he's got, in a 6-hour meeting, he's got 45 things to deal with, right? If I can, in my 7 minutes, if I can give him confidence that I know what I'm doing, then he can worry about the other 44 things. He doesn't worry about me. So when you prepare for a presentation like this, at least when I prepare for a presentation like this, one of the things I try and do is think, well, what do I want to leave my audience with? And pity maybe is something, I don't know, that might be something good. But really it's about giving you some insight into the things that we see in our organization and the things that we've changed and how our thinking has changed, so maybe you can apply that in your organization. So looking forward then, right, based on all of this, right, we had those 2 Sentinel events, we had the Shaw Court fire, and trust me, we had lots of other breaches and incidents in between there, but those are the 3 big ones. What are we going to do going forward? If you look at the future, right, the future of quantified self and home health monitoring, aging population, mobile health professionals, tablets and wireless and all that good stuff, how are we going to respond? How are we going to deal with a provincial clinical information system that's going to cost, I won't even go to dollar amounts, scads of money and take a long time? How do we enable that? How do we be part of that conversation? And so what we're doing is everything that we've done before is still applicable, but here's a few things that we're changing in our focus going forward. So we're still going to be focusing on the frameworks. We've got a lot of people that understand that the IT control framework that is based on COVID is really good and that there's value in that. But now we're going to take those frameworks and apply them to new systems and not just our existing systems. So we're going to build those frameworks into the development of our clinical information system. I tell my teams, all my teams, do not be the pedantic application of theory people, right? Do not implement COBIT just because you think you have to implement it. Do not implement ISO because you think you have to implement it. If there's value, then implement it, absolutely. But once you have those established frameworks, you can actually use those to change procurement decisions and design decisions going forward. So we spent a lot of time, we've learned how to sell COBIT in our organization. We've learned how to sell IRAM as a risk assessment methodology. We've learned how to sell lots of different things to provide value to the organization. Our next trick is to build that into the design phase and the procurement phase. One thing that we've really learned, and this is because we have service management working as part of my team, is that we don't have good service level agreements, we don't have good contracts, and we don't do a good job of continuous service improvement reviews from a security perspective. So all these things are from a security and risk perspective, and that's going to be a real big focus for our team in the next few years, where we are going to be putting standard clauses in our contracts so that we're building security and risk controls into our new procurements, and maybe you all do that. I know we don't do that. We don't do that very well, and that's definitely something we need to mature on for sure. We have a very large security awareness program, as Mike said. Trying to roll out a security awareness program to 100-odd thousand people is no small task. We've done a lot of phishing testing over the last 3 years in our organization, and we're not moving the dial. Things aren't getting better. So we're going to be looking at nudge theory and behavioral modification theory. We have access to a bunch of clinical psychologists who can help us figure out all of those neat ways of changing how to do things so that you actually get the behaviors that you want. Our security awareness program has evolved significantly over the last several years, from a poster campaign, in the coffee rooms, to videos, to training modules, to getting out in front of the individual teams on the units, to the phishing testing. And I think the future is going to look a lot different. We're going to be significantly more proactive with our testing. We're going to be significantly learning and adapting our security awareness program based on some of those things like nudge theory and behavior modification. I actually told my team on Monday that I'd love to give a presentation in early 2019, so 3 years, where you can envision the title of that talk being how AHS learned from the phishers and built a world-class security awareness program. Right? How are those people that are doing all that phishing work, and they're getting smarter and smarter and smarter? How do we get smarter and smarter and smarter to adapt that into our security awareness program? And then I've said this a few times, everything that we do is an organizational change management exercise. And one of the new younger guys that worked for me called me this summer and said, I want to learn what's the most valuable skill I can learn. And I think he thought I was going to send him on a Fortinet firewall class or something. And I handed him the ADCAR book for change management. And he just was stunned, right? Like, well, why is that important? And it's important because everything we do is going to be met with resistance unless we get people to sell it. Unless people want to do that for us, unless people think that there's going to be value. And the COVID example, I've said it 3 or 4 times, but I think it bears repeating. That COVID example was huge for us because we realized that even though the executive and the board wanted it, we had to sell it internally to our peers. So, like I said, what are the things that I want to leave you with? Well, I'm hoping to give you something out of this presentation that you can take back to your organizations and you can adapt in your own world. I would not wish any of those deformative events on anybody, but I will say that I'm a big fan of saying never let a good crisis go to waste. In every situation where you have a bad thing like that, go back to that advice that Bill gave me, right? Do not let this incident define you. You need to be defined by how you respond. And if you can do that and you can learn, you can make your program better, right? Be as proactive as you can, but also be as responsive as you can when things go bad. That's my talk. I'm not even sure how we did for time, but I have time for questions. But thank you very much for this. If you want to reach out to me via email or Twitter, please do so. I'd love to hear from you. Thank you very much. And I made it through the presentation without getting too sick or anything, so that's good. There we go.
Are you aware of any regulatory requirements that requires a company or organization to disclose whenever data loss?
So the question is, do I know of any mandatory disclosure legislation? So in Alberta, they want to make mandatory disclosure part of the Health Information Act. there was a big political brouhaha a year or so ago. One of the not AHS. One of the private clinics lost a laptop with 620,000 records on it, and the minister didn't get informed, and how do we notify the people? It was a big deal. So in the States, in California and other states, there are the mandatory disclosure laws. I think that will come to us, and if that legislation changes here in the probably next year or so, we'll probably see that in Alberta. I don't know. I don't follow the other provincial legislations, and I don't follow PIPEDA or PIPA federally. I guess PIPA is Alberta, but PIPEDA, I'm not sure if there's mandatory disclosure there. Anything else? Yes.
How do you see big data and IoT affecting you when it comes to security?
How do I see IoT and big data? So big data is, I'll do them separately, obviously. So big data is what we do, right? This is all the research. We have the Provincial Health Analytic Network, PHAN we call it, which is trying to combine the data warehouse at the ministry and the data repository at Alberta Health Services. We're trying to combine that and then provide access to that. So big data is absolutely huge, and we're trying to work with all of the different groups involved to find ways to, how do you identify what data sets you should be able to get access to? How do you provision the accounts? But also, how do you make sure that the data, if it's de-identified, can't be re-identified? And so as a sort of an aside, when my oldest daughter got into kindergarten a few years ago, Edmonton Public Schools said, well, here's we want to track the mental health of your child throughout his or her career, and so what we're going to do is we're going to track her postal code, her age, and a unique identifier that only we know, and her mental health data, right? And so I called the FOIP people, the privacy people there, and I said, I can re-identify exactly who she is because she's the only 5-year-old girl in my postal code. I know that. And so that's just a small example of these large data sets. If you can re-identify the data, then you're going to get into situations where it's not anonymized, and that's a real big problem. So we're working with our analytics teams, we're working with our privacy teams, our legal teams. We're working with the ministry as well to try and figure out how to have that data set that is de-identified and not re-identifiable. So that's the first one. The Internet of Things is important to us in that we have infusion pumps, for example, that are internet devices. We have pacemakers on individuals that are IP enabled. We have a plethora of different devices. We have complete building management systems that are IP enabled, and we need to find ways of protecting all those different networks. From the pure IP enablement and proliferation of those devices, that's really important for us because everything is going to have an IP address. From an Internet of Things perspective, I don't think we're going to see, at least in our organization, from a maturity point of view, we're not going to see a real change in anything. Like, we're not going to focus on IoT, but we're going to be impacted by the IP addresses. I'm not sure if that answered your question, but talk more later. Okay. Anything else? Yes, in the back there.
Is there no risk management or risk management sector within AHS? It seemed like that should kind of all part of it. And if there was there any clash between you guys and city to go through and do risk management within information security?
Yeah, so there's an enterprise risk management organization, and I'm not sure I completely understand the question, so I'm going to say a bunch of stuff and then tell me if I get it right. And so there is an enterprise risk management organization. That team has matured and grown at the same time that my team has matured and grown, and I've been able to be part of that ever since the start of that team. So I think that team has established itself as being extremely valuable in the organization, and we're seeing a lot of a lot of demand from the business units to say, how do we take these enterprise risk management concepts and build that into how we're going to prioritize our own individual business, whether that's mental health or nutrition and food services or primary care or whatever. And so we do have a connection there. And on top of that, we have a compliance, corporate compliance group as well that is run with internal audit, HR, finance, procurement, and IT. And so we work closely with them as well. So over the last several years, we've gone from a small internal audit group in AHS to a growing enterprise risk management group and a corporate compliance group. And my team's part of all three of those. So again, I'm not sure if I answered your question, but I'm happy to answer more questions afterwards if you want. Looks like I'm getting the hook. So thank you very much. I appreciate everything. I'm here for questions. I'll try not to get you sick. Have a good day.